Okay. Hello, everyone. We're going to begin the program after we allow a few minutes for attendees to join the call. And just give it a couple of minutes. Hi, everyone. We're just waiting a minute till everyone can join the call. Hi, I'm going to get started because I'm always punctual and people will go crazy if I don't. And I will go crazy if I don't. I'm Dr. Judy Regensteiner. I'm Distinguished Professor of Medicine and Director of the Ludeman Family Center for Women's Health Research. And I'm delighted to welcome you to this special program virtually. With women historically excluded from research studies, we need more research. There are many unanswered questions. And so the Ludeman Center studies women's health, sex and gender differences, and does research, particularly in the areas of cardiovascular disease, diabetes, and the intersection of mental and physical health. Ludeman Center is committed to a future in which research includes women and men and accounts for sex and gender differences. We do this through research, by mentoring and training, and through educational events. 10 years, Let's Talk was created in partnership with UC Health to educate the community about health through evidence-based talks. Each of these lecture series is uniquely created and presented by scientific and medical experts. This evening, we're focusing for the first time on the senses, the 5 senses as they're called. You'll gain important information on the topics of sight, smell, and taste, and hearing. You'll learn about the importance of these senses, common issues with the senses, how they differ in men and women, and why they are so powerful in our daily lives. We have 3 fantastic speakers with us today, and I'm very grateful to them for participating. We have Drs. Mina Pancheva, Courtney Wilson, and Sam Gubbles. You're going to be typing your questions into the Q&A box so that at the end of the session, we're going to take all your questions and answers. And I know I already have many questions, and I'm sure you will as well. So thank you very much. And without further ado, I'd like to welcome our first speaker, Dr. Mina Pancheva, who is an associate professor of ophthalmology with the University of Colorado Medical School. After finishing a glaucoma research fellowship at Massachusetts Eye and Ear Infirmary in Boston, Massachusetts, she did her ophthalmology residency and glaucoma fellowship at University of Pittsburgh Medical Center in Pennsylvania. She was recruited here by the UC Health Sue Anschutz Rogers Eye Center, where she's been practicing since 2009, taking care of patients and teaching residents. She has been recognized as an excellent educator by receiving the Academic Faculty Teaching Award from the Department of Ophthalmology in 2017 and again in 2021. Aside from her clinical research, Dr. Pancheva is involved in basic science research projects in trabecular meshwork and neuroprotection in glaucoma. Tonight, she'll discuss the differences between men and women in many eye disorders. This observation has allowed in recent years the development of studies that have investigated the type of relationship between sex hormones and various eye diseases. This presentation will focus on our current knowledge about sex differences in the ocular physiology and pathology. Welcome, Dr. Pancheva.
Thank you. I'm honored to be here. I'm going to try and share my screen. And that came out. Sorry.
It's okay.
Give me a second.
At the top of the screen, click Display Settings.
In the middle.
Top window just next to Show Taskbar. A little bit to your left.
And up.
Let's make more. How about I stop sharing and try again?
It's right. It says Display Settings in small.
Oh, I see.
You just click on that and you'll be fine. You just have to move your mouse up and to the left. Yep, just a little up. You're there.
No. I can't move that bar without clicking on something. I'll just stop sharing and do it again.
It's okay.
Share screen. There you go. Much better, I hope. All right. My talk is entitled Cherchez la femme, which means looking for the woman. So when I was invited to participate in this wonderful Let's Talk series, I was asked to talk about the importance of sight, the difference between men and women in different ocular conditions, and the power of sight. So I decided to structure my lecture in a way that I'll talk about some serious ocular pathology with higher prevalence in women, and I will throw in some curious research on the power of the women's eyes. So I'll try to give you the bad news that as we grow wiser, we'll all experience problems with the eyes, interspersed with some fun fact of how powerful women are just through their eyes. And how do I advance there? So first, I have no relevant financial disclosure. I don't know if that's mandatory for this talk, but I just wanted to make that clear. And as I said, we're going to talk about the importance, the common eye conditions of that involved mostly women than men, and why we have a very powerful tool in the sense of our eyes. It's easy to talk about the importance because we perceive up to 80% of all impressions by means of our sight. And in a study by Enoch and colleagues, 88% of participants ranked vision as their most valued sense. In fact, I've done this myself when I was giving lecture in the bioengineering department in Colorado School of Mines. I had then they were in person and we had a clicker system. So I started my lectures usually with the question, if you had one sense that you can't do without, and you can choose only one sense from all your senses, which one would you choose? The vast majority of the students ranked vision as their most valued sense. So that just made me feel important, and I went on with my lecture. Before embarking on some common ocular disorders, and particularly ones that are more prevalent in women, I would like to introduce briefly sex hormones. These are molecules produced by the gonads and to a small extent by the adrenal gland, which not only determine the primary and secondary sexual characteristics of an individual, differentiating men from women, but also participate in the functioning of various systems of the body, including the eyes. So the hormone that we know are testosterone, estrogen, and progesterone, or androgens, and they're the major players in many of our bodily systems. I don't need you to memorize this table. It's just a short table that shows how weak or strong evidence of role of the sex hormones involved in different ocular pathology is. And I'm gonna just talk about some of them, the ones that have some more popularity and are not the rare diseases that occur. So since we live in Colorado, let's start with the dry eye disease. Dry eye disease is a multifactorial disease affecting the tear film and ocular surface that involves symptoms of ocular discomfort, visual disturbances, and lubrication problems that can also lead to damage to the cornea. The tear film is not just a drop of water like some people think. It's very complex solution. It has a mucin layer which adheres the tears to the eye. It has an aqueous or water layer that nourishes and protects the cornea, which is the most front part, transparent part of your eye. There is a lipid oil layer which lubricates and prevents the tears from evaporation. And most importantly, we have these small meibomian glands, about 30 in the lower and about 40 to 50 in the upper lid, that create that lipid oil layer and to protect the tear film. This is where we love to put our eyeliners and mascara. The main symptoms that patients complain of are foreign body sensation, burning, photophobia, blurred vision, and itching. And I usually tell my patients that we kind of have the trifecta or quadrifecta, being women in menopause, living in Colorado, and especially if your job is mainly looking at computer. The prevalence of dry eye disease shows that women are affected by 2 to 4 times more than men of the same age, and the difference is accentuated after menopause, suggesting that sex hormones play a role in the pathogenesis of the disease. The estrogen and androgen receptors were found to be present at the level of all the tissues that make up the ocular surface, on the conjunctiva, cornea, at the level of the lacrimal and the meibomian glands. And still the role of estrogen in relation to the ocular surface appear controversial. And the most recent hypothesis that has been advanced is that during menopause, evaporative dry eye disease is not so much due to the reduction of estrogen, but rather due to the reduction of androgens. That I throw this in case someone is thinking that estrogen replacement therapy might help. May not, actually. And this is a short algorithm of the dry eye disease treatment. And as you can tell, when a disease has such a profound algorithm of treatment, you pretty much know that there is no good treatment for it. And I can give you the quick and dirty of prophylaxis of dry eye at the end of this Let's Talk series, but it's a complicated disease, and it requires a lot of patience and persistence with the dry eye regimen to try to avoid it and improve it. So for a little bit of fun, here I'm going to talk about women's eye contact and the power of women's eye contact, which seems to have a significant influence on men's interest. Numerous studies have shown that nonverbal behaviors exhibited by women, such as facial expressions and gestures, were associated with men's interests. For instance, a female Confederate in a singles bar who smiled after establishing eye contact with a man was more frequently approached, or a female hitchhiker received help more favorably from male motorists when smiling, which did not apply to a male hitchhiker. Sorry, guys. How about if a woman doesn't exhibit nonverbal facial expressions, which are commonly labeled as flirting behavior? So Gauguin and colleagues did a 2-field experiment and examined the only women's eye contact without any facial expressions and men's later interest. In experiment 1, a female Confederate established eye contact of 3 seconds or 1 second with a man when entering a bar. Duration of the return glance was the dependent variable, and analysis showed mean duration of the return glance was statistically shorter in the 1 second condition. In experiment 2, a female Confederate made eye contact with a man and looked at him less than 1 second, 2 seconds, or 4 seconds. And the presence versus absence of smile was the dependent variable. The longer duration of eye contact was associated with an increase of smiling. Just something curious. Now back to the serious part. Corneal disorders. The cornea is an avascular and transparent tissue and represents the most anterior portion of the eye. It consists of epithelium at the front, stroma in the middle, and endothelium on the inner side, the one that's facing your iris or the colorful part of your eye. If the normal cytoarchitecture of the cornea is subverted, as often happens in corneal disorders or pathologies, its refractive and biomechanical characteristics are consequently altered. Various studies have confirmed that estrogen, androgen, and progesterone receptors are present in the epithelium, stroma, and corneal endothelium. Corneal disorders can lead to changes in corneal thickness, corneal curvature, and corneal sensitivity. And interestingly, changes in all these three have been observed during the menstrual cycle and pregnancy, especially in the third semester. And this is particularly important in the surgical treatment of refractive defects like LASIK, in which it is essential that there is a stability to obtain satisfactory, long-lasting, and stable post-operative results without the risk of short-term reprocessing. For this reason, we actually do ask our patients sometimes to wait for the contraceptive pill or any hormone-based treatment to be stopped before proceeding with the treatment. Cataracts is another disease that is more prevalent in women. Estrogens have a protective role against lens opacification, reducing cataractogenesis. Estrogens have an antioxidant function. They're counteracting the formation of TGF-beta and reducing oxidative stress on the lens, which is one of the main pathogenic factors for the formation of cataracts. They also regulate the hydration and the ionic composition of the lens, helping to keep it transparent. And numerous studies have indicated that postmenopausal short-term hormonal replacement therapy, or SHRT, early menarche or late menopause, in which there is increased exposure to estrogen, are found to be protective factor and are associated with a lower risk of developing cataracts in advanced age. Glaucoma, my favorite since I'm a glaucoma specialist. It's a neurodegenerative disease characterized by the progressive loss of retinal ganglion cells. These are the cells that comprise our optic nerve. Their axons, which are the retinal nerve fiber layers, come together to form the optic nerve, and it causes structural changes affecting the optic nerve. On the left, there is a normal optic nerve. On the right, since we lost some axons, there is some thinning of the optic nerve. And then on the right is the most advanced optic nerve damage where there's no axon, so the nerve looks pale and cupped. Glaucoma causes progressive vision loss and is currently the leading cause of irreversible blindness worldwide. It is estimated that there will be around 112 million people with glaucoma by 2040. And I just wanted to demonstrate here how glaucoma robs the vision from the periphery, and people have like tunnel vision or in advanced forms. Postmenopausal women in whom there is a decrease in the level of circulating estrogen have a significant increase in the incidence of glaucoma and an increase in intraocular pressure of about 1.5 to 3.5 millimeters mercury compared to premenopausal women of the same age. Several studies have shown that longer exposure to estrogen due to early menarche or late menopause. By the way, menarche means when your menstruation starts. I'm not sure if you guys know. Is associated with a lower risk of developing glaucoma. Another curious fact, and Google's artificial intelligence can tell gender by simply looking at a retinal photo like this one. Until that day, we didn't think that there were any differences between male and female eyes. However, Google AI uses the neural network to tell them apart from just a photo of the retina. And how it does that is yet to be elucidated. So that's an interesting thing, that we actually differ even looking at a photo. And lastly, but pretty important, age-related macular degeneration. The longer we live, the more we see that in our parents and in friends. So the pathogenesis of AMD is multifactorial. It's characterized by the presence of oxidative damage, chronic inflammation, and the accumulation of extracellular material between the retinal pigment epithelial layer and the Brooks membrane layer in the retina, leading to central vision loss. Some studies have indicated that longer exposure to estrogen or hormonal replacement therapy decreases the risk of developing AMD in old age. Other studies align in the same direction, stating that low estrogen levels increase the risk of developing AMD. Despite these data, the Royal College of Ophthalmology's guidelines for management of AMD, based on meta-analysis, indicate that female sex is not a risk factor for AMD, and that the highest prevalence that we see in female is determined by our longer life expectancy. And to finish on a fun note, most studies of female facial masculinity preference have relied upon self-reported preference, with participants selecting or rating the attractiveness of faces that differ in masculinity. However, researchers have not established a consensus as to whether women's general preferences for male faces that are masculine or feminine. And several studies have indicated that women prefer neither. So Lyons and colleagues investigated women's preferences for male facial masculinity using standard two alternative forced choice preference trial, which is basically those surveys that they're selecting and rating which one they like. But this time they paired it with eye tracking measure to determine whether conscious and non-conscious measures of preference yield similar results. And they found that women express a preference for gaze longer at, and fixated more frequently on feminized male faces. They also found effects of relationship status, relationship context, whether faces are judged for attractiveness as a long or short-term partner, and confirmed that hormonal contraceptive users prefer more facially feminine male than those of non-users. And interestingly, once women start using a hormonal contraceptive, their preference for male facial masculinity decreases. This is all from me. Thank you, and I'll be happy to answer any questions.
Thank you, Dr. Pancheva. We're going to have the question and answer session at the very end.
Yes.
Thank you very much. And please put questions and answers into the question and answer box, and we're going to have our three doctors answering at the very end. Our next speaker is Dr. Courtney Wilson, and can we have her there? And Dr. Wilson is a postdoctoral fellow in the lab of Drs. Sue Kinnaman and Tom Finger on the Anschutz Medical Campus, where she works towards understanding the function of taste buds. She earned her PhD in neuroscience from the University of Colorado and is passionate about science communication to the wider public. Tonight, she's going to talk about how the chemical senses translate chemicals in our environment to sensory perceptions of taste and smell in our brain. She will cover the big picture of how this process happens, as well as discuss her recent work and decoding the circuit structure of the taste bud. Thank you, Dr. Wilson.
Thank you. I unmuted myself, right? I think I did. Good, great. We're awesome. Thank you for that introduction. As Judy said, I'm Courtney Wilson. I have a PhD in neuroscience, and I work in a couple different labs here on the Anschutz Medical Campus. Sue Kinnaman's lab and Tom Finger's lab, and both of them focus on taste. So while this talk is going to be about the chemical senses, my particular expertise is in taste. So here I have what are some olfactory or smell neurons, as well as a diagram of a taste bud that we will get into. So we're going to start with the really, really big picture and talk about smell and taste, the chemical senses, what are they even here for, right? Smell and taste, and also touch is actually a chemical sense in some, in addition to sensing pressure and vibrations, you can also sense things like heat and different chemicals. If you've ever used a rub on a muscle, one of those gel rubs on a muscle, you'll know that your skin can also sense chemicals. But the two main big ones are smell and taste. So they are basically being able to sense chemicals in the environment, right? Everything we eat, everything we smell, all around us is all made of up of small component parts called chemicals. Some of these are illustrated here. These are all things that exist in the food that we eat or in the drinks that we consume, that we encounter in normal life. So why do we even have these? Despite them not being thought of as important as vision, they're really important for a couple reasons. They, one, protect us and other organisms from potentially hazardous food and surroundings, right? So in our evolution, we, I'm sure, encountered a lot of leafy greens, many of which make poisonous things. A lot of nature makes poisonous things to protect itself. So if you think of apple seeds that contain a little bit of cyanide, or arsenic is in a natural chemical that we need to avoid. So our chemical senses allow us to detect those chemicals and avoid them so that we aren't coming to harm. In terms of smell, you can imagine how smell might be useful. If you say smell smoke in your home, you're going to know, oh, I'm potentially in danger because there might be a fire near me. So I need to make decisions and move away from that danger so as to protect myself. So first off, they're protecting us from potentially dangerous stimuli in our environments. Secondly, they allow us to seek out those things that are beneficial, right? So as people with bodies that need a lot of energy, we need things like carbohydrates, we need protein, we need salts. Our chemical census allows us to detect and find and ingest those things that are going to help us run our bodies, right? So our taste systems allow us to detect things like protein and sugars or carbohydrates, and allow us to reject those dangerous things, while our sense of smell will alert us to the presence of, say, food. If you smell baking bread somewhere, you are more likely to go to the room where you're sensing the smell of baking bread from, because you know that your body can find some nourishment there. And even more than in just food consumption, which is what we largely think of smell and taste being involved in, this can be involved in a lot of our, smell in particular can be involved in a lot of our, say, relationships. There was a really interesting article I read where someone had collected a bunch of sayings from like 4-year-olds, what they thought dating was. And one of them said something like, oh, it's when two people go out and smell each other, which is funny, but it's also kind of true. Like, we use perfume, we smell each other's hair. So smell is, you know, deeply intertwined with our relationships with other people, with our dogs. I know I love that newborn puppy smell or newborn baby smell. So it's really a holistic version of giving us value in our life, in our relationships, and also in what we eat and consume. So I'm going to give us the sort of big picture of how this works. We're going to talk about how the chemical senses, the smell and taste, actually do that first magical step of figuring out what a chemical is so that it can send that information to the brain. And I'll go through how each of those works. I'm a basic scientist, so I'll be focused on just, you know, the basic function. And then we're going to talk a little bit about things we don't know, and mostly what we don't know about how men and women differ, and people of different biological sexes different. So we have smell and taste depicted here. Here's, you know, cut an image of through a human's head. And we encounter these chemicals either airborne in the air, so something that's already sort of floating around in the air outside, as you can see here. And we can sniff that in. That gets into our nasal cavity, where we have neurons or brain cells that are specialized to sense those chemicals and send that onward to the brain. If we're ingesting something, we can chew it up in our mouths, and our saliva helps dissolve those component parts and those chemicals so that they can come into contact with our taste buds, which are all over our tongue as well. And so that's how we get our sense of taste. Another sort of pathway that we have for our sense of smell is that when you're chewing up food, some of those chemicals in your food actually become airborne and travel up the back of your nose. We call this retronasal olfaction, or retronasal smell. And so while you're chewing up food, you can actually smell some of that that's going up the sort of reverse direction into your nose. There's a fun experiment if you ever have a jelly bean. It's best with jelly beans because they're very particular flavors. But if you have one, don't look at it because your visual system can actually hint at what the flavor is. But plug your nose, so you're cutting off airflow, you're cutting off that retronasal olfaction. You chew it up for a bit, see what you can sense, and then open your nose at some point, and the explosion of flavor will be impressive to you, I promise. So that's always a fun thing to just see how much of your sense of flavor is actually smell. So how do our smell and taste systems actually recognize these chemicals apart from one another? This is how do we tell a sugar molecule from a molecule that causes the smell in bananas from citric acid, say? So these are all made up of the same component parts, the same molecules. They all have carbon, they all have oxygen, they all have hydrogen, but they're in different forms, right? So they're essentially in different shapes. So I'm going to simplify these by making them into different simple shapes. And what we have done as organisms, all the way from little microbacteria up to us and everything in between, we have evolved these things called chemical receptors. So these are molecules that all of your cells make. They're encoded for in your DNA, and then your cell, if it's supposed to express that receptor, takes that DNA, makes a protein out of it, and puts it on essentially the outside of the cell where it can come into contact with things that might lock into it. So you can think of these chemical receptors as sort of locks, and these stimulants, sugar, banana, smell, and say acid, so hydrogen ions. The acid is essentially just hydrogen ions that come off of molecules quickly, as the keys. So we have a key and lock system where we're recognizing these things based on shape. So if you eat something that's very sweet, that sugar is going to come into contact with your sweet receptor that's on certain cells in your mouth, and it'll generate a signal that can then send that signal to the brain. Same with your sense of smell. If you're inhaling something near a banana, you will get this molecule from a banana. It'll lock in to that receptor, and unlock that cell, signaling to your brain what's going on. And some receptors, particularly in the taste system, don't actually work so much like locks. They're more sort of kind of like doors in this metaphor. So if we have, say, hydrogen ions or acid, that there are doors or portals in the outside of your cells that are busy detecting sour that only fit protons, right? They only fit hydrogen ions. So once that hydrogen ion goes through that very particular door, that's what generates the signal and allows your brain to understand what sort of stimuli you're encountering. So all of this is based on shape. Where are these receptors expressed, right? Let's get into the anatomy of this. And I'll go through smell first, and then we'll talk about taste. So this is a diagram of what your olfactory or smell epithelium looks like. So it's just a thin layer of cells that sits inside your nasal cavity. It's actually just on the top, very bittiest bit of your nasal cavity. Most of it is actually dedicated to what we call respiratory epithelium. So that's busy trying to defend against bacteria and whatnot. But your smell happens at the very top of your nasal cavity. And the main players here are these olfactory or smell neurons. So these are actually neurons, they're brain cells that live kind of on the outside of the skull in your nose. Their cell bodies, where their nuclei are and all the DNA are in this epithelium, and then they have this long dendrite that extends and makes these kind of finger-like cilia, and that is where those receptors reside. So if we're looking here, this is sort of the top of your nose. Will be the nasal cavity. So this is where they're going to come into contact with all of the things that are airborne and get dissolved kind of grossly in the mucus of your nose. So once those keys essentially hit those receptors, they're going to turn on one or more of these olfactory cells and send that message to the brain. Over here is what this actually looks like in a micrograph. I believe this is mouse tissue, but here we have one of those sensory neurons. You can see its little finger-like cilia that express those receptors. And what you can see here is there are a lot of other cells here, and they're the supporting cells. We call them sustentacular cells. But really interestingly, because I know I'm going to get asked about it, in COVID, these supporting cells are the ones that we think are getting directly infected by COVID-19. So these supporting cells have a different kind of receptor. It's called ACE2, and it's a kind of receptor that COVID-19, the virus, kind of hijacks to grab onto and invade that cell. So we think that the supporting cells, not the actual neurons, are getting infected by COVID-19. And since those neurons aren't being supported as well because the support cells are infected, we think that's maybe part of what's causing this smell deficiency that we found in COVID-19. So where does the signal go after that? So this is an image. This is the epithelial layer we were just looking at. It actually crosses a bone structure called the cribriform plate and gets into the olfactory bulb. So these neurons take the message to neurons in the olfactory bulb. They take the message then further into the brain. So what's really interesting about the smell system, and it's kind of special among the senses, it's the only one that bypasses this structure called the thalamus. So in our brains, there's a structure called the thalamus. You can think of it like a gatekeeper of sensory information. So it takes in information from your taste system, your visual system, your hearing system, vestibular system, and it kind of does a check of like, should we send this to the rest of the brain? Cool, we will. And so smell actually bypasses that and connects directly to your memory centers, to your fear centers. This is partly why we think that smell in particular is so evocative of memories and so evocative of emotion in comparison even to other sensory systems. So we'll move on from smell, go to taste, my personal favorite. While you can detect hundreds of different chemicals with the receptors in your smell system, taste is mainly focused on 5. We have sweet, sugars, bitter, all manner of bitter chemicals. Those have their receptors. So we have the modality and then the receptor that receives that signal over here. Bitter things, umami. Umami is one that a lot of people haven't heard of, but it means savory. So it's basically the detection of protein in the foods that you're eating. Mushrooms have a lot. Parmesan cheese has a lot. Meat has a lot. Those are all very umami qualities. Salty, we also detect. So that's one of those that the receptor sort of functions more like a door. So in table salt is sodium chloride, right? So that's 2 molecules. And when those dissolve, these doors, these portals or channels on your cells are actually letting sodium ions pass. And that's what's causing the signal to arise. Sour is similar. So we talked about sour being chemicals that lose their hydrogen ions really easily. So those hydrogen ions can pass through a different door on different cells, and that signals that there is sour in the mouth. So where are these receptors in your taste system? They're in the taste bud. So this is an image of a mouse taste bud taken by a colleague of mine. This is the top of the taste bud and the bottom of the taste bud, and it's sort of this garlic clove shaped structure, and contains, these are individual cells in both blue and red. They're kind of spindle shaped and they extend all the way from the taste pore where the receptors are, where they come into contact with things in the mouth, all the way down to the base where they're contacting these fibers, these nerve fibers that are lit up in green that then communicate that to the brain. So interestingly, while smell is working with brain cells as their first step, the olfactory neurons are neurons, they're brain cells. These are actually a derivative of skin cells. So these are tongue skin cells, and they're communicating. They act a lot like neurons, and they communicate electrically to the nerve cells that then take that information to the brain. So taste buds are all over your tongue. You even have some in your larynx and in the top of your mouth. They're kind of all over the place. But the 2 main parts that they are, the anterior tongue, the front part, they're in these structures called fungiform papillae. They're named that because they look like mushrooms. And then in the back of the tongue, if you have a partner at some point, stick your tongue out really far, those little bumps in the back, those are your circumvallate papillae. And they're these actual trenches that kind of invaginate into your tongue and are packed with taste buds. And we think the ones in the back are probably your last gatekeeper of this is healthy, swallow it, this is gross, spit it out. So we think that's what they're up to, while the front of the tongue might be doing more, what level of salt is this, or what kind of bitter is this? So these taste buds, here's another diagram of the taste pore. These taste cells talk to the nerve fibers that innervate them. On the right here, this is an electron micrograph, so really high resolution image of a taste bud. Here we have the taste pore, all these taste cells. These are all their nuclei that contain the DNA, these circles here. And so once they communicate this through the taste bud, they go to nerves that come from the front and the back of the tongue and the larynx. They go to the brainstem, they go through the thalamus because they're not as special as smell. And then they go to this region of the brain called the insular cortex. And it's called that because it's kind of like shoved in between 2 other areas of the brain. And that is where we're getting the perception of sour, sweet, bitter, salty, umami, and making decisions about whether we're going to eat or spit out that food from there. So this is a talk about biological sex and how these things are affected, right? So the thing that you can take away from this is we have a lot of work to do in taste, and in particular, but taste and smell, over biological sex differences. What is true is that, especially in taste, there seem to be some differences in how we register fat. Now, I didn't mention fat as one of the 5 big tastes, but there is some evidence that it might be a 6th taste that our taste buds help to find and detect. And so there's some indication that females do this differently from males and have different preferences for fat, and that these are affected by receptors that are on your taste bud. So likewise, one of the big things that people who were born female go through is pregnancy, right? So there are also some studies that indicate that hormones during pregnancy can actually affect the function of the taste bud and the smell system, so that people are, anecdotally, it's very common for people to report hypersensitivity of smell, very different taste preferences and taste desires. And all of these we think are probably rooted in the fact that your taste bud and as well as your smell system can be affected by the hormones that are circulating in your blood. So as hormones change in these different procedures, so does your system of smell and taste. So with that, I think my time's probably up. So I will give it off to the next speaker. Thank you so much for listening.
Thank you. Thank you, Dr. Wilson. That was very interesting. And I never thought about there being taste and smell differences in men versus women, but it was interesting to hear about it. And we'll talk more about this in the question and answer period. Our next speaker is Dr. Samuel Gubbles, who is an otolaryngologist, more specifically an otologist and neurotologist in Denver in our ENT clinic. Dr. Gubbles graduated from University of Arizona College of Medicine in 2000 and is affiliated with Children's Hospital Colorado, UC Health, University of Colorado Medicine, and the UC Health Ear, Nose, and Throat Clinic. Tonight, Dr. Gubbles' talk will focus on how hearing loss can result from a large variety of causes. There are multiple types of treatments available, and he'll talk about that. In this presentation, entitled Hearing Loss Causes, Evaluation, and Management, he will review the causes, evaluation, and current treatments for hearing loss, as well as promising therapeutics. Thank you, Dr. Gubbles.
Thank you, Judy, for having me. Let's get the slides up. Oops, sorry, at the beginning here. Well, thank you again very much for having me, and a pleasure to present with our other presenters today. And again, feel free to send any questions to the chat as Dr. Regensteiner requested. So we'll cover in this brief presentation hearing loss and go over some of the more common causes of hearing loss, some sex and gender related differences, talk about our general approach and treatments for hearing loss, and then a bit of research updates on the topic, particularly an area close to mine. An area of research is the future with regenerative therapies for hearing loss, and where things stand in that arena. So hearing loss is very common. As I learned in an earlier presentation, it's not nearly as important as our vision, but it's still very common. And we see about 1.5 billion people worldwide with hearing loss. That's about 20% of the global population. And about 430 million of those have what is characterized as disabling, which there's certain criteria, but you can imagine that more severe forms of hearing loss. So that's about 1 in 8 Americans who have hearing loss, overall 10% of the population. And you do see some generational differences, baby boomers and Gen X. But I think probably more important than that is, and I tell patients in clinic this all the time, is if we all live long enough, the majority of us are going to go on to develop some hearing loss. It's about 51% of all octogenarians and up to 62% of nonagenarians. Congenital deafness is common as well. Well, I think it's the first or second most common congenital abnormality, 1 in 500 newborns. There's some studies looking at the cost, just the kind of societal cost, not to mention the individual costs, which we'll cover a little bit later, of hearing loss are rated over a lifetime. And this is about 15 to 20-year-old data, so it's only more now, of around $300,000. So when we think of hearing loss broadly, there's generally two types. There's conductive hearing losses and sensory neural. So conductive hearing losses are, you can think of it that the sound waves that enter through our external ear and go through the ear canal, then are transmitted to the eardrum, which then is able to vibrate our chain of hearing bones, the ossicles, and then pass that sound energy into the fluids of the inner ear, the cochlea. The conductive loss is any problem with those sound waves actually getting to the point that they can vibrate the fluid of the inner ear. When we think of sensory neural losses, those are any problem in the cochlea, or for that matter, in our hearing nerve, or any of the brain stem or central auditory processing centers that we have, as we do for other senses, as nicely covered in the previous talks. In general, conductive losses, a lot of times hearing aids will work well for them, but there are different types that may be amenable to medical treatment, such as simple as middle ear infection, as we see commonly in children, that we can treat with antibiotics. And generally, there'll be a transient phenomenon, and hearing will return back to baseline after the infection and subsequent fluid clears. There are other problems, sometimes after head traumas or previous surgeries, but sometimes in other contexts that I'll cover here in a minute, that cause a conductive loss that we can fix surgically, usually working through the ear canal, occasionally through an incision behind the ear, where we can go in and, for example, patching a hole in the eardrum or repairing the hearing bones after maybe they've been destroyed from a number of different potential causes. There are also problems, and one of them happens more often in females, where the hearing bones stop vibrating properly, and that's amenable for surgical repair. One of the more common surgeries we do. Sensory neural losses, we generally do not have surgical repairs to directly to improve them almost uniformly. We use hearing aids as the mainstay, and when hearing aids are no longer working well, that's when we start thinking about cochlear implants. And indeed, surgery is involved with cochlear implantation, but we're not necessarily fixing the hearing loss directly, if you will. We're rehabilitating the sense of hearing using a device. So common causes of acquired hearing loss, not surprisingly, noise damage and aging, as I covered, aging being very common, and noise-induced damage more often in men than in women, but still very common, are the most common causes. These both present with a high-frequency hearing loss, and over time can go on to involve the middle and lower frequencies and worse increase in their severity. There are a number of medications which can potentially cause hearing loss, but I think as germane clinically, it's really three main classes of medications that we worry about causing hearing loss. And those are certain types of antibiotics called aminoglycosides, which can have a toxic effect on the hair cells of the inner ear, which we'll get to here in just a minute. Another class is called the loop diuretics, such as Lasix, certain type of powerful diuretic medications used for heart failure or swelling of the legs. And then the last are certain types of chemotherapy agents, ones that are based on platinum, so platinum-containing chemo. Those are the three kind of classic major offenders as far as drugs that can cause ototoxicity. There are many others reported to do it and that can even potentially do it, but less commonly, and some would be more of a reversible pattern. Another common cause for hearing loss, so we see sudden hearing loss as an entity where somebody just wakes up and without identifiable cause can lose hearing. Another disorder we see pretty commonly, Meniere's disease, where we get hearing loss in combination with bouts of vertigo, which can be disabling for a number of reasons, a relatively frequently seen cause of hearing loss in a practice such as mine. And then what I listed here, otosclerosis, is a disease process that's very interesting, where it's an abnormality of bone turnover of near the hearing bones. And what we see is a progressive hearing loss, excuse me, that's conductive, not sensory neural. And we do see an interesting connection that there does seem to be some this disease process that can accelerate during times of hormonal shift, such as menarche or menopause, but most commonly during pregnancy. In fact, it's kind of a common question as we teach our trainees that if you have a young female patient who during her first pregnancy notices that one ear develops a significant, a noticeable hearing loss during the course of pregnancy, that's generally kind of the setup of a question of a patient who has this disease process, otosclerosis. So there is some hormonal sensitivity. It's poorly understood on the whole exactly the cellular mechanism of it, but certainly clinically we do see that pattern. Now, males get this process as well, and females who are not in times of hormonal shift can have it also, but it is one that kind of in certain situations you see that kind of a classic presentation, if you will. But again, circling back, noise-related damage and age-related hearing losses being by far the most common causes. So what happens in our inner ears when we lose hearing, and this is focusing on the more common sensory neural inner ear losses. When we lose hearing, most of the time we are losing the hair cells of the inner ear. So the hair cells of the inner ear, you can liken them to the photoreceptors of the eye or the taste receptors just covered. They're the primary receptors of the mechanical sound energy, and they transform that sound energy into electrical signal that's then passed along the auditory nerve into our brain. So we know around 80% of the time that the first thing to happen is that we see changes with regard to these hair cells, and generally loss of outer hair cells. That's these top 3 rows of cells that you see with this V configuration on their top in the upper right panel. And then as things progress, we start to see loss of the inner row of hair cells. There's 1 row of inner hair cells, 3 rows of outers, and then a beautiful cytoarchitecture of supporting cells underneath them. And so, again, after we lose the primary sensory cells, the hair cells, over time, we see loss of the auditory nerve starts to degenerate and retract back and becomes less healthy because it's not having the healthy input from these hair cells that that is required to keep the nerves, the nerve fibers healthy over time. And as relates to regeneration in the inner ear, we know that in mammals and in higher vertebrates, when we lose our hair cells, there's no regeneration that occurs. You see in this bottom left panel in a rat, there's a healthy complement of outer and inner hair cells on the figure A, the top left. In the middle, you see damage after there's been damage, such as experimentally, typically this is done with noise or ototoxic medications. And then we see over time no regeneration occurs. And this is different from chicken and reptiles, where we see after damage, they will reform new hair cells, even a relatively new complement of functional hair cells. And so this has been a very active area of research since over the last 30 to 40 years, looking at how do we understand how these lower vertebrates are able to, but higher vertebrates are not, understanding the important underlying cellular mechanics of it, and are we able to develop treatments designed to allow humans to regenerate the hair cells of the inner ear, the whole area, the area broadly kind of classified hair cell regeneration. So we know that before we actually even clinically manifest a hearing loss, and before we see signs of damage in people's inner ears, that there are changes going on in the inner ear where those hair cells that communicate with the nerve fibers, we start to see the area of interaction, which is called a synapse, we start to see that it degenerates. And you see, this is some animal modeling. Look at the little dots here, basically showing highlighting these synapses, and that we see before clinically apparent hearing losses occurred, we see that you get this synaptopathy. And this has been likened and found basically clinically in humans, that it's not uncommon. We see patients come through who have a totally normal hearing test when we test them in our standard quiet conditions, but they're reporting significant problems when they start to have noisy condition, when in any background noise, things start to break down. And this is a newer area of understanding of hearing loss, kind of early hearing loss, called hidden hearing loss. And there are even some companies right now working to develop pharmaceuticals to see if we can reverse that process early on. When we look at our pediatric population, we see different causes of pediatric hearing loss. About 50% of the time, it's an environmental factor. Let's say that they received potentially an ototoxic medication as an infant, or potentially more commonly meningitis can be a common cause of hearing loss in children. 50% of the time, however, there are genetic causes, and about a third of that in general, there's a identifiable syndrome, and about 2/3 we don't see that there's a syndrome, but there's still a genetic problem at work. And then we can work through that to determine what the nature of that genetic problem. It doesn't necessarily at this point open up new avenues for treatment, but there's great hope that in the future we'll have targeted genetic replacement strategies, which I'll talk about here in a minute, that if you know you have a certain defective gene, we might be able to design a gene replacement to put in a non-mutated copy and thus restore hearing. An exciting area of our field. So what are the consequences clinically of hearing loss? We see many of them, and I think everybody knows somebody who has hearing loss and probably has seen these things happen. We see social isolation is a very common one, that you stop going out to dinner with friends because it's just too hard to hear at a restaurant. This often leads to or can be associated with depression. We know that hearing loss, if you look at large populations, can lead to reduced educational and employment opportunities and also reduced productivity. And interestingly, there's actually an increased fall risk associated with having hearing loss, even though we tend to think of the inner ear functions of hearing and balance as pretty separated. We do see that in patients who have normal balance function, if there's hearing loss present, that there often can be balance problems that relate. So more for us to understand there than we kind of have for a long time thought of. One of the more important connections that has come to light over the last 10 years or so is that the hearing loss is one of the few modifiable risk factors for the development of cognitive decline or dementia. This is a very important area of research currently, and we know that not only if you look at patients 70 years old and older and follow them over a 10-year period, patients who have hearing loss develop dementia at a higher rate than patients who do not. And there are some data, not as strong of data, but some data suggesting that the use of hearing aids in patients with hearing loss will return that additional risk back to more of a baseline level. And we also know that hearing loss is frequently undertreated. Only about 20% of patients, when we look at treatment utilization for hearing aids and cochlear implants, only about 20% of patients who would benefit from a hearing aid actually go on to get one. And this is multifactorial, as you might imagine, the costs involved, ability to be evaluated, and amongst others. So that number that's disappointingly is only about 2 to 12% of patients who would benefit from a cochlear implant actually go on to get one. And these are patients just by nature of them qualifying for a cochlear implant, they have more severe hearing losses. So we have a long way to go in being able to better utilize what we have as very effective treatments for hearing loss that, again, currently are very poorly utilized. But I think this renewed focus we have now based on our better understanding of hearing loss as a modifiable risk factor for dementia, hopefully will fuel change at a more rapid rate. When we look at sex differences, we know that it's a bit of a mixed picture. We know that there are differences between anatomical, just how long the cochlea is in males versus females. The male cochlea is a little over a millimeter longer typically than a female. And we know that when we look at different electrophysiologic ways, so not testing we would do in a booth, but other ways we test hearing without a behavioral response, there are differences between men and women, both in males and females, both in animal models and in humans. We also, for a long time, have noted different patterns of hearing loss with aging and with noise exposure as far as the frequencies involved and how commonly we see that the low versus high in males versus females. That said, that has been a little less clear recently since there's not as much of an effect now as there was, say, 40 years ago with regard to noise-induced hearing loss. That's not that it's still not a problem, but I think there's more uniform adoption of noise protection in the workplace. And so we're seeing this picture change a bit. There's been very inconsistent data when we look at sex differences with regard to hearing loss. And I think my interpretation of it is it's just between average differences in lifestyle, nose exposure, and unique illnesses and their different prevalence in males versus females, we're seeing differences in the patterns of hearing loss. Interestingly, some recent studies kind of trying to untangle this showed less difference in European populations between male and female versus American studies, and that's very unclear to me exactly why that may be the case. We do know that there is a postmenopausal acceleration of hearing loss that suggests a protective effect of estrogen, and indeed, estrogen replacement has been found to slow age-related hearing loss on some level. Not the strongest of data out there, but there are data suggesting that. And so we know that there's that. And we also know during development, even with that, when we have an estrogen defective mouse, their inner ear, especially their organ of Corti, doesn't form properly. There's also some data to suggest that women may be more prone to ototoxic effects of different medications, not actually the medications I mentioned before, but some other ones, some cardiac medications amongst others, than men are. Again, those data are not quite they're a little more opaque, but some suggestion of it. And we do know clearly that women are more likely to seek and use hearing aids than men are. So those are the differences that we see. And as I mentioned, a bit of a mixed picture there. So how do we approach hearing loss? Well, we do age-appropriate testing. We then do a medical evaluation because there are certain patterns of hearing loss that get us concerned that somebody may be harboring a certain type of a tumor or other disease process. So an evaluation in the otology clinic or with an otolaryngologist in addition to audiometric testing. And then depending on that, there may be imaging involved. Sometimes more often in pediatric patients, we might consider genetic testing. There's different counseling depending on what we may find in the course of this workup. There might be suggestion in children of enrollment in birth to 3 programs, FM systems at school, and other services to help them. And then we move on to different treatments. The mainstay, as I mentioned, are hearing aids. As you see here, there are numerous types of hearing aids. Some are more visible than others. The second from the left is probably one of the more recent designs and one of the more commonly used designs, what's called a RIC or receiver in canal hearing aid, but other smaller designs, even some not pictured here that are completely deep in the ear canal and cannot really be seen, but they require more trouble to insert and remove for battery changes and so forth. So in addition to hearing aids, assistive listening devices, again, as I mentioned, FM system, personal amplifiers, TV listening systems that can help in certain tailored situations that we look to, as you see, also amplified phones, headphones. And then, when patients get beyond where those sort of measures are effective, then that's when we generally start to think about whether they might be a candidate for a cochlear implant. But while we have very strict candidacy criteria for cochlear implantation that need to be met in order to meet the FDA guidelines and thus have insurance approval for cochlear implantation. As a general rule, what we tell patients is if you have appropriately well-fit hearing aids and somebody's still struggling with their hearing ability, then that's time to at least think about coming in for candidacy evaluation for a cochlear implant. So cochlear implants work differently than a hearing aid. They're not really making it louder. What we're doing with the cochlear implant is we insert an electrode into the cochlea that winds around. Our cochlea has 2.5 turns in humans, and the implant winds around 1 to 1.5 turns of those. And what we're doing is you see these little electrode contacts. The different companies have different number of contacts, but there's electrodes marching along. There's electrode contacts going along this electrode that we insert, and they're spaced out. And we're taking advantage of the fact that the inner ear is organized in a high frequency to low frequency pattern. And so when we insert this electrode, and then we turn the device on, it basically takes incoming sounds and it breaks up on an ongoing basis, low, mid, and high frequency sounds, and then transforms that into electrical signals and appropriately distributes them on this electrode so that we're stimulating low, middle, and high frequencies. And with doing that, we're directly stimulating the nerve. So we're no longer really using the hair cells any longer. We're just directly stimulating the nerve and basically taking advantage of the fact that the cochlea is a very convenient, organized housing to be able to stimulate the hearing nerve. Currently, you see over 750,000 worldwide. I think actually we just eclipsed the million mark recently as far as global cochlear implants. So it's a more and more common procedure that we're doing, and that's for different reasons. There's been technological improvement in the devices, significant technological improvement. We're able now to, in the past, we couldn't preserve if you still had some residual hearing. A lot of times it would be lost when we perform cochlear implant, whereas these days we're very keen on hearing preservation, cochlear implantation. So there's a lot of efforts we make to be as atraumatic and preserve residual hearing along with the cochlear implant so that potentially patients can both use regular acoustic hearing, whatever's left with a hearing aid, and also take advantage of electrical hearing from the cochlear implant. Surgical improvements in how we do the surgery and design our soft tissue work. And again, so what we do as far as the electrode insertion, use of medications around the time of surgery have all streamlined the process, and just our general experience with doing it has made it, again, much more streamlined, and it led to broadening of the selection criteria. And the long and short, as you see mentioned, as you see listed kind of there on the right, is that over time, since these became popularized in the early 80s, in the past, you had to have only the patients with the most severe to profound hearing losses would qualify. Whereas now you can have a much more moderate level of hearing loss, but if you're still struggling with your hearing aids and meet candidacy criteria, you'd be a candidate for a cochlear implant, and good studies showing that you would benefit from it. So that's kind of broad strokes with regard to cochlear implants. I think speaking to their success, the three original designers of the cochlear implant who you see listed there recently won an award in 2013 called the Lasker Award, which I hadn't heard of, but this is an innovative award for designing modern day cochlear implants. And apparently I think about 70 to 75% of Lasker awardees go on to get a Nobel Prize. So we may see that cochlear implantation and the designers of the cochlear implant ultimately go on to receive a Nobel Prize. These are kind of what they look like. These are the top parts, are what you see are the implanted parts, and with their attendant, the little electrode coming off it's just the tip of that ends up winding around in the cochlea. The remaining part of this is called the receiver stimulator. That part is implanted completely beneath the scalp tissues through a small incision behind the ear. Once that healing has taken place about 2 weeks later, then we're able to put the external portion of the device. These are a little older ones and bigger than we currently see, but the external portion, which looks like a big hearing aid with an extra little round wheel at the back that is magnetically attracted to the inner part and passes the sound and power signal into the inner part. We don't ever have to change batteries or anything like that on the implanted part. That's usually good to go for the long term. So that's kind of what cochlear implants look on the outside and what we put in on the inside. So the last area to cover is hair cell or not necessarily hair cell, but regenerative therapies for hearing loss. And so, as I mentioned, there's great interest because it would be nice if we could avoid device dependency and the other aspects of hearing aids and cochlear implants that would be better treated if we had a more natural way to restore hearing. And so there's great interest in this, and there's a lot of progress that's been made. But as I mentioned earlier, the inner ear is very determined to not regenerate, and it's hard to study regeneration in an organ that's very determined not to regenerate. And this is in contrast to Courtney's area of the olfactory system, which has a beautiful system of regeneration after insult. We're really lacking that in the inner ear. There's a number of different strategies. One of them is using gene transfer. So maybe we'll replace a defective gene, or there are certain genes that we know are master controls of generating new hair cells. And this is an area I've done some research. Some of the images on the right, these are on the top, newly regenerated hair or overabundantly regenerated hair cells. And there are other genes that we know are critical for generating new hair cells, and we've come to understand them. And we know that delivering them to animals with hearing loss, we can regenerate new hair cells but under specific contexts, and it's not as ironed out as we would like it to be. There are certain type of drugs that we know have a similar effect, kind of affecting a master control to generate new hair cells. And many companies right now, a number of prominent companies who are developing pharmacotherapy treatments, so drugs to try to enhance regeneration in the inner ear. And then there's an area of trying to manipulate inner ear stem cells or even cell transplantation, but I would probably put that, unfortunately, towards the bottom as far as how distant that may be as far as realistic treatments for hearing loss. And likely it's in the future, my guess is it's not, hearing loss is very heterogeneous. And so likely it's going to be that for certain types and perhaps congenital hearing losses, we're going to have gene replacement treatments. But for acquired hearing loss, as we get older, it'll be pharmacotherapy treatments, or maybe treatments that are directed towards inner ear stem cells, or maybe even transplantation, but still early days and hard to know exactly where things are heading. But safe to say that we are seeing significant progress as measured by many things. One of those being that we see industry getting very interested in this area, and that tends to always accelerate the progress beyond what we get under more just traditional research arenas. So hearing loss is common and increasing in prevalence. It is a modifiable risk factors for dementia, which is really brought up. How cognizant of it we are. There are gender differences present, but clinical manifestations are unclear in some large modern studies. Hearing aids and cochlear implants remain the mainstay of treatments, but there are medical therapies and other targeted surgical treatments for certain types of hearing loss that we look to. And we'll see regeneration, I think, in our lifetimes. We're already seeing it, and we will only continue to see focus on regenerative therapies for hearing loss. Again, they're nascent at this point, but they're emerging, and we'll see more of them as time goes on. So thank you for the opportunity to speak, and I'm happy in our session to follow to take any questions that you may have. I think you're muted, Judy.
I'm muted. Whoever heard this phrase, I'm muted, before COVID? Nobody, but we all hear ourselves saying it a lot. So thank you all. I really appreciate our three terrific speakers. And we have a lot of questions, so I hope you'll be able to answer them all. There's questions on the Q&A, and I received some other questions as well. So first of all, Dr. Pancheva, are there some breakthrough therapies in our site for treatment of glaucoma? You're muted too. In fact, you all are. You can unmute.
Well, the breakthroughs are some new medications that are coming up and some new surgical techniques. But I think the biggest breakthrough that we're all waiting for is in the realm of neuroprotection and neuroregeneration. And we are very excited that NIH set up a platform or a program that's called Audacious Goals, which opened the door for funding of research that will allow us to try and transplant retinal ganglion cells, like stem cells, retinal ganglion stem cells, and also some new neuroprotective approaches. So, but these are still in the realm of research. So in terms of from lab to clinic, I would say we are still working on new medications that have come up to the market and some new surgical techniques that have come up to the market.
Thank you. Dr. Wilson, how is anosmia diagnosed? The person who asked it says she's had no sense of smell as long as she can remember.
So anosmia. So anosmia is the inability to smell things. And it can be, so there are ways to diagnose it. If you go to, say, an otolaryngologist, and they'll have a panel of odorants or smells for you to smell. And if you can't detect them, you are anosmic. But my guess is if you feel like you don't have a sense of smell, you probably are anosmic. So, and there are ways. A lot of people don't actually get it diagnosed because there's not a whole lot that we can medically do to help that currently. As Sam was mentioning earlier, all of our sensory systems function and develop and are based on activity. So One of the ways that it's suggested that people improve or work on their sense of smell if they're having smell issues is to do practicing smell very, very strong things like a lot of garlic, or hopefully good things like a lot of garlic, a lot of banana, which is a pretty strong smell. And so that can sometimes help recover activity, but it depends on what form of anosmia one has. So if it's genetic and congenital, it might not be fixable. Whereas if it's after a head injury, a lot of people lose their sense of smell in head injuries because of where your all that stuff is. That can sometimes recover a little bit better. So,
Dr. Goebbels, what causes? Thank you, Dr. Wilson. What causes tinnitus?
Well, in general, we think that tinnitus is a maladaptive response by the brain to the hearing loss that has occurred in our ears. And what I mean by that is, if you think of it, it's kind of likened to a phantom phenomenon, like when somebody has had a diabetic maybe has had a below the knee amputation and they go on to develop leg pain, even though they no longer have a leg because of the amputation. The thought with tinnitus is sort of similar with that once we've lost hair cells and lost hearing in our inner ears, that the brain replaces that, but the hearing having been lost with generation of tinnitus. And we know this in other contexts because there's certain surgeries that I'll do, for example, where they're part of the surgery because of tumors or what it may be, whatever it may be, we actually have to cut the hearing nerve in some people. And in general, if they had tinnitus before, after the surgery, they continue to have tinnitus, which tells us that it probably wasn't coming from the ear because we've severed that connection. So again, that's the current thinking. That the thought is that the hair cells have a certain tonic rate of firing, that they're always interacting with that nerve and discharging and causing a pulsing, even in the quietest of environments where it's all the way from high frequency to low. All those hair cells have a periodic firing, just kind of signaling to the brain that they're out there and they're active. When the hair cells have been lost, the thought is that nerve no longer has that tonic input from the periodic firing that goes up when that particular frequency of whatever hair cell it is stimulated. And so then that then generates the response of the brain to create tinnitus.
How treatable is it? I understand some people get hearing aids, but I understand it's a terribly unpleasant problem for a lot of people.
Agreed. Yeah, it's not currently not very treatable, unfortunately. There are certain contexts where if we think there's some in-ears change, there's certain things that can be tried. But if you look at large populations of people with tinnitus, unfortunately, we're still left wanting treatments directly for it. There are 2 or 3 medications and 1 device currently in human clinical trials. So we may see that change over the next 5 or 10 years, let's hope. But currently, our strategies basically try to help patients manage how impactful the tinnitus is on them. And one of the more established strategies is what's called masking strategy. So that can be as simple as using a white noise generator at night when that's a frequently bothersome time for people with their ringing may not be able to get to bed. There's also, you see commercials on TV will cure your tinnitus. And that's generally targeted towards they will evaluate you and treat you with a hearing aid if you have hearing loss, or no amplification if not, but that aid may have a feature that puts in a low-level noise, white or pink noise, that can have this suppressive effect on the ringing. Not necessarily a cure, but it is an established way to treat that. I mean, not as a cure because the ringing's still there when you take the devices off, but it is an established way to mitigate how much it's impacting people. There's other strategies, cognitive behavioral therapies and tinnitus retraining therapies that are out there. These are different methods to work with patients to help minimize how much tinnitus is affecting them. But that's a long-winded answer to say we currently don't have treatments for tinnitus. I'm hopeful that will change, but that's kind of how we approach patients with tinnitus. And, our audiologists are an important part of this process. Once we've done a medical evaluation and started the conversation about these strategies, there are a more detailed dive that like our audiologists here at UC Health are able to give with regard to some of the things that I mentioned.
One of the things I love about the Let's Talk program is it provides the public with information about what's evidence-based versus what's, a wild-eyed cure that isn't validated by evidence. So I always want people to know what's scientifically validated rather than, even if we don't know something, I'd rather you all know that than think that there's something that there is not. Dr. Pancheva, one of the questions I grapple with in my own research is the question about the role of estrogen. And I heard it come up a couple of times, in several talks tonight. How much do you think the loss of sight in women may be affected by the loss of the female hormone estrogen at the menopause? In other words, what role does menopause versus just age play on, the loss of vision for various reasons?
Well, basically, mostly it's the cataract advancement but luckily it's a reversible vision loss. We can treat it, we can do cataract surgery, but that's the main, I would say, well-established reason for vision loss and involvement of estrogen. So it has like a higher level of evidence than when we look to the other diseases like dry eye disease or even glaucoma. And definitely not macular degeneration. As I said, it's controversial and it's certainly believed not to be affected by the estrogen. But cataracts, yes. And women have higher prevalence and can develop earlier cataracts than men. And that's compared postmenopausal women with premenopausal women at the same age. So they were able to do the study with women who are at the same age, but some are post and some are premenopausal. So the good news is that one we can take care of.
Cataracts, yeah, that's good. Dr. Wilson, I have a COVID-related question. Long COVID has been associated with not just loss of taste, but also people are experiencing weird smells. What is the mechanism here?
So the short answer is we don't know. But you can imagine after, say, a system deteriorates, the challenge is when it's regenerating, and smell is one of your few senses that is able to, the neurons are actually able to regenerate. I know that there's a whole myth about you never growing any new brain cells after you are born, but that's a myth mostly. There are a couple new places where you grow new brain cells, and one of those supplies your olfactory system. But after something is regenerating, there's always the challenge of it has to wire up correctly, right? So if something has been degenerated to such a level where it needs to like rewire completely, some mistakes might be made in that, would be my guess. Shorter answer again is I don't know.
And that is perfect because we don't know. That's
yep.
what it's for. Do women smell natural gas leaks like mercaptan better than men?
So I saw this question and I did a really quick search, and what I found out is I don't think so, not to my knowledge anyways. There's plenty of things I don't know, obviously. But again, this is an area where we have sort of a dearth of knowledge of taste and smell in comparison to a lot of other sensory systems. And this is in part because we've philosophically as humans thought of them differently. So in, Aristotle times, they made all of these references to, the really important senses are like vision and hearing, and they are important. No offense. And other things, but, smell and taste were sort of considered these more base sensations. And so we've had less time doing deep research about these systems. Touch even worse, probably, and vestibular system and proprioception even worse are other senses. And so we're not as far along, and especially gender-wise, covering differences between biological sexes, we really don't know. My guess is that the variability within groups would be more within women and within men would be more than between them, but that is a complete guess on my part. So.
Well, there's a lot that isn't known about sex differences, and particularly about women's health.
Yeah, turns out.
It hasn't been studied all of that long. So lots of work for all of us. We'll not run out of our profession. We can keep doing research. Dr. Goebbels, some of us judge our hearing based on TV volume. Is there a correct level before you need testing?
No, I think there's there's variability in the level setting between manufacturers, and so it's not a standardized level that we'll see with TVs. Now, over time, I think if you've always listed it at 10, now it's at 40 consistently, that's probably a good indirect indicator. Also volume on your phone, things like that. So certainly, those are indicators that that hearing loss might be at work, but they're not as certainly not standardized. The standard still is a comprehensive audiogram in a sound booth.
Here's a question about what about aspirin causing eighth cranial nerve damage?
Yeah, and not so much the nerve. Aspirin and ibuprofen and the salicylates. We don't think it's necessarily, we don't know, but not necessarily a nerve problem. We know that there can be what is usually generally thought of as a reversible toxicity to the inner ear, generally manifested as tinnitus. You have to take pretty high dose, and a lot of times you might be risking kidney toxicity before you'd actually get to the dose you'd need to cause your tinnitus, but it's possible. If you took high enough doses. So in general, aspirin and NSAID related tinnitus and hearing loss, if that doesn't, not common, but if that's happening, is thought to be reversible upon stopping the medication. And we think that the effect is in the cochlea as opposed to the eighth nerve itself.
Dr. Pancheva, did you have something to add to that?
No.
Oh, sorry. What causes an aftertaste with artificial sweeteners?
So a lot of artificial sweeteners have kind of a bitter aftertaste. And while there's not a lot of people that have looked at, the primary taste of something versus the aftertaste of something that you get a little bit later, but what I would say is that everything that we're ingesting isn't just one chemical. Like, unless you're just taking spoonfuls of sugar, you're taking it in context with a lot more things. So a lot of artificial sweeteners, while they have a sweetening effect, they affect your sweet receptor. They may also have structures on the same molecule or same group of molecules that also affects your bitter receptors, but not quite as much. So the first sensation you're getting might be sweet, while the second one might be a little bit bitter. So everything is a little bit more complicated than just one taste in.
Good answer. I don't know what DED is, but one of our attendees asked, is it safe to take estrogen to prevent DED?
This is dry eye disease, I think the question.
Oh, please.
Actually, I would say absolutely not. There are studies that have shown that estrogen-only HRT can worsen dry eye symptoms. So if anything, you would like to stick with the combination estrogen-progesterone, which I would stick for other reasons as well, but including dry eye disease. And most of all, even in that group, there is like a big nurse database, and they did the data from the women's health study. They showed that estrogen-only HRT they had about 69% increase of risk of dry eyes compared to 29% in estrogen and progesterone. As I mentioned in my talk, actually, the most recent theory is that it's not the decrease in the estrogen, it's more the decrease of the androgens that might be the cause of the dry eye disease. So if anything, we need to throw in some testosterone maybe as well. So it's complicated, but I would encourage you not to take estrogen if you're taking it for that purpose.
And typically for people with a uterus, estrogen will be given with progesterone.
Yes, exactly.
People who had a hysterectomy, they could encounter that. So good advice. Another question for Dr. Wilson. For patients who experience hyperphagia, are certain taste buds upregulated to increase more food-seeking behavior?
So there's I'm gathering this is maybe getting into one of the big myths about taste, where, that taste map you have where part of it is sweet and part of it is sour and part of it is salty. I hate to break it to you, it's poppycock. So the taste buds, every single taste bud has all of the cells necessary to detect bitter things, sweet things, sour things, umami things. And so it wouldn't be an upregulation of taste buds. But what I will say is that your taste system is changing all the time. And not only are your taste buds regenerating and rewiring, we're actually trying to figure out how once a taste bud, like its cells are dying, some are dying, some are being born, how that rewiring happens so that you're still tasting everything properly. But your taste system is changing all the time based on internal need. So if you are, say, salt deficient, your drive to go seek salt will be increased. And we don't totally know the mechanisms for that, but we know it's happening. Does that sort of answer your question?
Well, it does mine. I wasn't the person who asked it, but I think it's well, thank you all. You were fantastic speakers, and I want to thank you all for coming. I want to thank our audience for participating, and please come to future Let's Talks. We'll be having one in a few months, another one, and we're thinking about bringing them back in person in the new year. We used to have Let's Talk with a dinner as well as talks, and people love those. But if we do, it'll be a hybrid so that people can still attend remotely if they would like to. So we're just thinking about it, and it won't be to the new year, but something to look forward to. I want to thank everybody then for attending and for participating, and please respond to our survey to give us evaluation. We do listen to all your comments and thoughts. Also, check our website, www.ludemancenter.org, for news about upcoming events and other educational events that the center has. Thanks again. Thanks to Lindsay Andrews, who works very hard on preparing this program, and to the center staff. Good night.
Thank you.
Thank you.
Thank you.